Hello, everyone. I'm honored to present at the 2021 Annual Updates meeting. Quick introduction. My name is Umer Najib. I'm an associate professor of neurology at the Rockefeller Neuroscience Institute at West Virginia University. And I'm going to talk today about the use of transcranial magnetic stimulation in neurology. Quick disclosures. I'm going to talk about on and off-label application of devices. I serve as a principal investigator on clinical trials sponsored by Teva, Lilly, Electrocore, and Thalamocortical, and I'm also a consultant for Allergan and AbbVie. So transcranial magnetic stimulation, as the name suggests, it's transcranial, so across the skull, magnetic, and a stimulation. It's a way of non-invasive brain stimulation or non-invasive neuromodulation. And I'm going to talk about a few diagnostic applications and a few therapeutic applications of TMS. The focus would mainly be on the characterization of neurobiology using TMS, certain TMS paradigms as physiological biomarkers, and prediction of treatment response. On the therapeutic side of things, we'll briefly talk about stimulation either alone or in combination with other interventions that may be beneficial in neurological disorders. This is a roadmap of my talk today. And I'm going to talk about most of these things individually as we go along. As you can see in the diagnostic list of things, there are the main usages that we'll talk about today would be investigating central motor conduction, motor cortical output mapping, cortical reactivity, cortical plasticity, metaplasticity or functional connectivity, and then cortical excitatory and inhibitory balance or intracortical excitatory markers. On the therapeutic side of things, I'm not going to talk about medication refractory depression, which, as you would know, is one of the FDA-approved therapeutic uses of TMS, since our psychiatry or behavioral medicine colleagues typically use TMS in this regard. I'll focus more on migraine, stroke, and neuro rehabilitation, and then a few words about Alzheimer's and some of the other things. If you remember from your old days in physics, the Maxwell-Faraday equation, which suggested that a time-varying magnetic field is always accompanied by a spatially varying non-conservative electric field, and vice versa. And this was the basis of electromagnetic stimulation, and dates back as far as the late 1800s, when in the picture on the left, picture A, you can see Jacques Arsène showing that when one places the head into an electromagnetic coil, they experience phosphenes and vertigo. Later on in the early 1900s, Sylvanus Thompson showed that magnetophosphines can also be induced from the stimulation of occipital brain cortex. And on the right, you see Anthony Barker, who's regarded as one of the most influential figures in the current form of TMS, who in the 1970s came up with a device which was capable of generating peak fields of 2 Tesla with an approximate rise time of about 100 microseconds or so. Eventually, in the 1980s, the mid-80s, the TMS as we know of today was developed. Currently, there are several TMS systems that are available for diagnostic usages and certain therapeutic indications. A couple of them shown here, MagStim and MagVenture, they're FDA approved or cleared for the stimulation of peripheral nerves and muscles. The one shown on the left, NeuroStar, was the first FDA-approved device for the treatment of medication-resistant depression. Now, MagStim, MagVenture, NeuroStar, NextStim, and a few others, including BrainsWay, Apollo, Cloud TMS, they're all FDA approved for the treatment of medication-resistant depression. The one that you see on the right, NextStim, is also approved for cortical brain mapping. A couple of the systems, BrainsWay and MagVenture, are approved for the treatment of OCD, and one of the systems is also approved for smoking cessation. So just a quick overview of TMS. In TMS, during the application of TMS, a coil is placed on the head, and as you can see from the diagram on the top left, the electromagnetic field, the magnetic pulse crosses the skull, and then the rate of change of the magnetic field induces an electrical field, which in turn induces the tissue current. The coil seen over here is a typical figure of 8 coil, where the maximum magnetic field is in the mid part of the coil, where there's some summative effect of the opposite magnetic fields. During the talk, I'm going to use a few terminologies. These are the different types of transcranial magnetic stimulations. Single pulse is typically applied every few seconds, and mainly has usages in certain diagnostic paradigms. Also is used to measure what we call the motor threshold, which is the basis for determining the intensity of stimulation needed for a particular individual. So this is useful for in almost every application of TMS, because the first step is the use of single pulse TMS to determine the motor threshold. There's another paradigm called the paired pulse TMS, where 2 stimuli, either from the same coil or from different coils, either from the same hemisphere or different hemisphere, can be applied, separated by a few milliseconds, and depending on that separation, the conditioning stimulus can either have an inhibitory effect on the test stimulus or a facilitatory effect on the test stimulus, and we'll talk more about that. And then there's repetitive TMS, or rTMS, where trains of stimuli are applied to a brain region, and then depending on the frequency of stimulation, it can either have an inhibitory effect or an excitatory effect. Typically, low frequency repetitive TMS is inhibitory in nature, and high frequency, typically 5 Hertz or higher, is excitatory in effect. When the goal of rTMS is to inhibit the target cortex, typically 1 Hertz stimulation is used. And when the goal of rTMS is to increase the activity of the target cortex, typically 10 or 20 Hertz stimulation is used. And then there's another form of stimulation, which is asynchronous trains, called theta stimulation, and we will talk about that as well. Okay, so this is essentially similar to what I was talking about. It'll be a little bit easier to understand. So 1 Hertz stimulation is inhibitory, 10 Hertz or 20 Hertz excitatory. And then within theta burst stimulation, there are different paradigms. The 2 commonly used types of theta burst stimulation are continuous theta burst stimulation or intermittent theta burst stimulation. Continuous theta burst stimulation results in long-term depression-like changes, so is inhibitory in nature, and in intermittent theta burst stimulation, or ITBS, produces long-term potentiation-like changes, or and in other words, is excitatory in nature. Let's start with central motor conduction. Central motor conduction time can be estimated using TMS by the onset latency of the first stimulation, T1, minus the onset latency of the second stimulation, T2, which is spinal stimulation. Now, of course, this can be a useful diagnostic tool, and it can the estimation can be made more precise by the use of F-wave latency if that is added to the TMS stimulations. The TMS, when combined with imaging modalities, can be useful in studying cortical reactivity. TMS can induce a focal interference with the brain activity, and what that does is essentially adds causal information to the brain imaging finding. This can have both diagnostic and therapeutic implications. Next, we'll briefly talk about motor cortical output mapping. One of the TMS systems, if you recall from my earlier slides, is FDA approved for motor cortical output mapping. TMS, when combined with neuronavigation, can produce excellent spatial resolution. One of these systems, the NextStim system that I showed you earlier, studies have shown that it can produce up to 1 to 2 millimeters of spatial resolution, and can be useful in cortical output mapping. Now, this has clinical utility in pre-surgical mapping, and here you can see this. This is a real patient where the cortical output mapping on the left is done using TMS and is compared to the cortical output mapping done by direct cortical stimulation using subdural grid electrodes on the right. And as you can see, it resulted in pretty accurate maps. There's growing evidence of data now that this form of non-invasive brain stimulation can be really useful in pre-surgical mapping. Next, we'll talk about cortical plasticity, which is a very exciting area of research. Now, dating back to the mid-1990s, we knew we had an insight into cortical plasticity, and Sadato in the mid-90s showed that with tactile tasks that required discrimination, there was activation of the striate cortex in congenitally blind individuals. Cohen, a couple of years later, showed that this activation of the striate cortex was actually necessary for Braille reading in the blind. And this was made possible by using TMS by creating a virtual lesion, meaning inhibitory use of rTMS or repetitive TMS. Using inhibitory paradigms, a virtual lesion was created. And as you can see, when the striate cortex was blocked, there was a significant increase in the error rate. More work followed, and this is another example of a study that showed that compared the detection and identification of brain symbols. And again, using TMS by creating virtual lesions, we learned more about the role of striate cortex in Braille reading, which showed that when the somatosensory cortex was blocked, both the symbol identification and symbol detection was affected. However, when the when the occipital cortex was blocked, only the Braille identification, symbol identification was affected and not the symbol detection. Here's an example of an interesting case, again showing the role of striate cortex in Braille reading in the blind. This was a case of 63-year-old woman who was blind since birth, an expert at Braille reading, and unfortunately suffered bilateral occipital strokes, which did not otherwise cause any neurological deficits. However, she was unable to read Braille after her strokes. Just a few examples of how TMS has been useful in studying the cortex and the cortex, the cortical reactivity and the cortical plasticity. Now, we know that using rTMS, modulation of cortical activity is possible. Some early translational work in this regard was done in the mid-2000s. Here an example of Valero Cabre showing that inhibitory rTMS on the cortex decreased the uptake of 2-deoxyglucose, and excitatory rTMS on the cortex increased the uptake of 2-oxyglucose. However, the interesting thing in some of the follow-up studies was that there was not only the direct effect on the cortex, but also a connectivity mediated impact on other structures of the brain on the 2DG uptake. And you can see that by the figures on the right, where although where distant areas from the target sites also showed a change in the uptake depending on the type of stimulation. And this led to a lot of further work in the connectivity, showing or investigating the neural connectivity in humans. Using theta-burst stimulation, we now know that the cortical reactivity can change over time after high frequency stimulations, thereby implying cortical plasticity or metaplasticity. And more recently, TMS has been combined with other modalities such as EEG and functional MRI to study neural networks, which is obviously a growing area of investigations. Lastly, we'll talk about the intracortical excitatory and inhibitory balance, and we'll talk about a few examples in this regard. So this can be studied by using paired pulse stimulation. Paired pulse, as the name suggests, it's a pair of pulses, two stimuli, typically separated by 1 to 20 milliseconds. Can be done either by using the same coil or two different coils, either the same target or using bilateral stimulation to study interhemispheric inhibition. And this graph down here shows you what we typically see with paired pulse stimulation. Depending on the time interval between the two pulses, the result is either an inhibitory effect or an excitatory effect. The inhibitory effect is typically seen at around 2 milliseconds, excitatory effect between 8 to 12 milliseconds, and then again we see an inhibitory effect. Similarly, with interhemispheric stimulation, it's useful to study the effect of transcallosal fibers, the inhibitory effect of each hemisphere onto the contralateral hemisphere. And we now know from the follow-up work that the short interval cortical inhibition is GABA A mediated. The intracortical facilitation is NMDA mediated, and then the long interval cortical inhibition is GABA B mediated. So how does it help us? Now, here are a few examples. Using paired pulse in patients with chronic pain, TMS helped understand that chronic disinhibition occurs in chronic neuropathic pain, but not in chronic nociceptive pain. And regardless of whether it's the lesion nerve or an unlesioned nerve area, because it's a cortical phenomenon. And as you can see from here, this is studying intracortical inhibition, and patients who had neuropathic pain showed chronic disinhibition as compared to patients who had nociceptive pains or controls. The effect was only on intracortical inhibition and not on intracortical facilitation, again providing insight into the underlying mechanisms. It's a GABA A mediated phenomena and not an NMDA mediated phenomena. From the single pulse studies in migraine patients, the early evidence came in the late 90s that there was an increased occipital cortex excitability in patients who experienced migraine with aura. This was shown by the phosphine threshold, which was significantly lower in patients who had migraine as compared to the controls. And then using paired pulse, the paired pulse stimulation provided further insight that even when the target was motor cortex, there was an increased intracortical facilitation, but there was no change in the long interval intracortical inhibition. However, there was a change in the short interval intracortical inhibition. So in short, there was reduced cortical inhibition, which was GABA A mediated, and then NMDA was implicated in the increased cortical excitation. Moving on to some of the therapeutic applications. As I mentioned, I'm not going to talk about the the medication refractory depression, where the first device was approved in 2008, and since then, now we have several TMS devices which are either approved or cleared for the treatment of medication refractory depression. The next approval came for migraine, where a TMS device, which we'll talk about in a bit, was approved initially for the abortive treatment of migraine in 2013. At that time, it was known as Spring TMS. It was approved in 2013 for the abortive treatment of migraine with aura. And then around 2017, preventive treatment was added to the indications as well. It's now approved for both abortive and preventive treatment. For the abortive treatment, we do have randomized sham-controlled trials. However, for the preventive treatment, the data constitutes mainly of open-label studies. The typical stimulation-related adverse events are reported as tingling, tinnitus, and lightheadedness. The underlying mechanism of action is thought to be the disruption of cortical spreading depression, which is a neurophysiological substrate for the migraine aura. And we now have data to show that there is down modulation of the thalamic nociceptive circuitry and down regulation of thalamocortical neurons after cortical stimulation using TMS. The initial data for the use of TMS as an abortive agent came out in the mid-2000s. And this led to the landmark study that was done in 2010, which was using a single pulse transcranial stimulation for the acute treatment of migraine. This was a randomized, double-blinded, parallel group sham-controlled trial, and led to the FDA approval of TMS. where after using TMS, 39% of the patients experienced pain freedom at 2 hours, as compared to 22% of the patients in the sham group. 2-hour pain freedom is typically used as the primary outcome measure in abortive treatment trials for migraine, and this benefit was maintained for up to 48 hours. Now, as TMS was used for the abortive treatment, the open label studies, the follow-up phase 4 studies, which looked at the TMS use as an abortive agent, also showed a signal that the patients using TMS as abortives were experiencing less frequency of TMS attacks over time. This led to some observational data, which was first presented in 2015, and then led to this trial, which was known as the ESPOUSE study, which then became the basis of the FDA approval for preventive treatment. Now, this was an interesting study design. In this study, a performance goal, which was a statistically derived placebo response, was used as a comparator. The primary endpoint was the mean reduction from the baseline in headache days compared to that performance goal. And as you can see from the graph, patients using TMS did have a significantly higher reduction as compared to the performance goal. Now, as you would know, the bar for approval of devices is significantly lower than for the approval of pharmacological therapies, and this FDA deemed this to be enough for the approval of this device for the prophylactic treatment of migraine. There's been some mixed data, some interesting data where repetitive TMS or rTMS has been used for the prophylaxis of migraine. Here I'm sharing some data from Italy, where high frequency, which is excitatory rTMS to dorsolateral prefrontal cortex, was used as a preventive treatment of migraine. It did show a reduction in the migraine attacks, also showed a reduction in the use of abortive agents and the functional health index. Another small study showed that inhibitory stimulation at the vertex was potentially useful as a preventive treatment. Some of the more robust data has come from targeting the motor cortex. This study, published in 2016, showed that excitatory or 10 Hz stimulation on the motor cortex showed a significant improvement in the reduction of headache days, and the response was comparable to Botox for up to 8 weeks. It did not last as long as the typical response seen with Botox, but did show some promising results. Continuous theta burst stimulation has been used for migraine, again targeting the motor cortex, and shown some promising results. Although the data is pretty mixed when it comes to the use of rTMS or repetitive TMS, the hypothesis is sound, because we know from several preclinical studies that even a single pulse of TMS modulates the thalamocortical activity, decreases the thalamocortical activity. So targeting the cortex can be used to modulate subcortical networks. However, as I said, more work needs to be done to identify the appropriate targets and the appropriate treatment paradigms to help with prophylactic use. I will briefly talk about the use of TMS for stroke or stroke rehab. Now, TMS is not approved for stroke rehab. However, there is encouraging data to support at least further exploration of this avenue. Now, we know that the molecular and the cellular changes after stroke are reflected by a significant reorganization of the post-lesional cortex. And this pattern of the post-lesion map depends on, one, the lesion size, and also on the lesion position or the location in the brain. The TMS studies have been helpful in the functional mapping of post-stroke recovery, as they provide insight into the motor cortical reorganization. And these insights can be valuable, for example, for surgical planning in patients who have undergone such reorganization after strokes. In addition to that, it also helps for the investigation of post-stroke brain plasticity that may result from therapeutic interventions. Now, here is one such example. Now, we talked about that TMS can be used to modulate cortical excitability and cortical and cortico-subcortical connectivity, but this can be also done with therapeutic intent. For example, there's increasing evidence now that during voluntary movement generation after stroke, the interhemispheric inhibitory drive from the unaffected hemisphere to the affected motor cortex is abnormal. And leveraging that, TMS can be used as a therapeutic intervention. This was from our group a few years ago, where contralateral stimulation, so stimulation to the non-lesion hemisphere, resulted in improved grip strength and finger tapping from the lesion hemisphere. On these graphs on the right, read non-stimulated as lesion hemisphere and read stimulated as the non-lesion hemisphere, the hemisphere which was stimulated. And as you can see, after stimulating the non-lesion or the contralateral side, the ipsilateral side showed an improvement. And that improvement was shown more so in patients with stroke than in controls, again supporting the evidence of one, reorganized maps, and number two, an abnormal or changed cortical excitability after stroke. Having said that, we still need more robust studies to explore this avenue. One challenge that we see in stroke studies is that this is such a heterogeneous group of patients that it becomes challenging to study, one part of the brain or one type of therapeutic application on one target of therapeutic application. So patient selection is key in order to study a particular target and a particular type of stimulation. Over the years, different brain regions have been targeted to study the cognitive domains, and they've all produced mixed results. You can see this from the list of studies that I'm showing over here. Having said that, more recently, there have been studies that have combined multifocal repetitive TMS with cognitive training, and they've shown some promising results for the therapeutic potential. However, we still need appropriately powered and controlled randomized clinical trials to evaluate for this therapeutic potential. I'm going to conclude with a shameless plug of our TMS program at the West Virginia University, where we have 3 state-of-the-art TMS labs. We have 5 advanced TMS systems with integrated neuronavigation, EEG, EMG. Of course, we provide a clinical treatment for patients with mood disorders, but we also have multiple clinical trials ongoing in the areas of stroke rehab, memory disorders, addiction, and human performance. Talking about the stroke rehab, we have a growing cohort of patients with expressive aphasia, where inhibitory stimulation on the contralateral or the non-lesion hemisphere, coupled with speech therapy, is showing significantly better results compared to speech therapy alone. We are going to publish that data soon, but this is an exciting area of research, as you can see. I once again thank you for providing me the opportunity to talk at the 2021 annual updates meeting. You can see my email address on the screen. I'd be happy to answer any questions if someone would take the effort of emailing me those. Thank you once again.